Welcome, Dr. Shereen Lim. I'm so excited to have you here today to talk all about airway health and why this is so important for our kids' sleep, their health, and their overall well-being. But before we dive into that, I would love to know what is one thing that you have done today to take care of you?
Yeah. So this morning, before work, I had a later start. So I was able to go out for a coffee. I downloaded a new book. I can't recall the name,
That's okay.
but it was all about, you know, do the impossible, something along those lines. And, how can you actually make a bigger impact in the world? And just being able to look at some of those questions and have the time to think about what I want to do and contribute to the world. And it really had some very empowering questions. And I think that was one way that I actually was able to take care of myself. Yeah.
Yeah, that's a lovely way to start the day, not rushing right into it. So can you tell us how you got into working on children's airway health as a dentist? Because this is, I imagine, something that not all dentists are doing.
Sure. So it was around 12 years ago, my husband snoring prompted me to learn more about airway health. Yeah, his snoring was really frustrating me and really disturbing my own sleep. And one night I was so frustrated, got out of bed, and I decided to read more about these dental sleep appliances that we can use for adults with snoring and obstructive sleep apnea. So they reposition the lower jaw forward and they help keep the airway open and helping people breathe better and make snoring less of a problem. And so as I learned more, I enrolled in a graduate diploma in dental sleep medicine to learn more about these appliances, to become qualified and offer this to more people. And I really started to understand that these problems actually are linked to serious health risk. And when we do these dental appliances, what we're really doing is we're actually offering a Band-Aid solution to compensate for the poor jaw development that has occurred. And I wanted to know, how come we don't grow jaws better in the first place? When we're growing, you can do early interceptive orthodontics to help the jaws grow better. And how come we're not doing that? A lot of the time in orthodontics, we refer children for orthodontic assessment, age 7 to 8 years. But many times they're put on a regular recall program, watch and wait. And then at age 12, it's braces, sometimes taking out teeth to straighten them. And we're making the teeth straight, but we're not necessarily addressing the poor jaw development. And we're missing that boat to optimize the way that our airway is growing. And during that time, many children, when their airways aren't growing, they're not sleep and breathing well. And so I really wanted to get to the root of the problem, seeing all these serious health consequences down the line and recognizing that we have the opportunity to deal with it in the early years of life.
Yeah, that sounds incredible. I wish that you had been around when I was a child. So, what are some signs that we can look out for in our children's breathing, their sleeping, their jaw structure when it comes to airway issues? Like, how do we know if there is a problem?
Yeah, first of all, with sleep, it's so critical to get good sleep, particularly in the early years of life when brain development is most rapid. And so a lot of the time when we ask parents, how well does your child sleep? As long as that child is sleeping through the night and not bothering mum and dad, parents think their child is sleeping well. So what we really want parents to understand is that when a child is sleeping, we want them to be silent. We want them to be fairly still, not thrashing about and doing 360s. And they should just look really rested and peaceful. So we don't want them to be sweating or looking too labored in their breathing. And they should have their mouth closed and be breathing through their nose. That's when we're going to get the most restorative sleep. And so warning signs of poor disrupted sleep or poor breathing during sleep include things like mouth breathing and snoring or gasping for air. Children that are tossing and turning or sweating, they don't look peaceful. If there's any teeth grinding, it's a very strong red flag that there is a breathing disturbance, as well as any bedwetting. Any unusual sleep positions, for instance, with the neck hyperextended or sleeping in the stomach, on the stomach. And unexplained awakenings. Sometimes when we have children that wake up and come into parents' rooms, why are they waking? Is there a breathing disturbance? And when we wake children up in the morning, they should be fairly refreshed, in a pretty good mood. And these are all warning signs. If they're grumpy or they're feeling quite tired, they're warning signs that breathing may not be good or restful. They may not be getting restful sleep. Now, during the daytime, when children don't sleep well, they're not necessarily tired in the way that adults get. They can be more overtired or displace those type of symptoms of hyperactivity or difficulties with attention and concentration or poor emotional regulation. So these children going 0 to 100 or not able to regulate their emotions as well. So a lot of these things, even anxiety, these things we need to look at. How is a child sleeping? And very importantly, what is the quality, which is so impacted by the way they breathe. So they're the warning signs that we're really looking for in terms of what do we want to see with the child's sleep.
And when it
Did you
comes
ask?
to, oh, sorry.
Yeah, go for it.
When it comes to mouth breathing, is there any time when that is normal and we should expect to see our kids mouth breathing, or is it predominantly we just want to be talking and eating with our mouth and just breathing through our nose?
Yeah, we want to see breathing through the nose day and night, and with the lips sealed as well. That is the optimal way to breathe. When we breathe through our nose, the nose is specially designed to warm, filter, humidify the air before it goes into our lungs. So it actually reduces the risk of upper airway infections, even including ear infections, and allergic rhinitis type of symptoms. When we breathe through our mouth, it changes the way that the muscles rest and the way that our muscles work. And so it's a more low-toned muscles. And then we can get other myofunctional disorders where the muscles don't work properly. It will affect the way that we speak, the way that we chew and swallow. And so we really do want to get the muscles really working in balance with the lips sealed and breathing through the nose. Now, the other thing is, I think if we have the mouth hanging open, what we'll recognize is that if we all our muscles are floppy during sleep, when we have the mouth open, it's easier to snore than when we have the mouth closed. So we know that we have a more stable airway when the mouth is closed. So that's going to lead to our most deepest and restorative sleep. But why do we really need to pay attention to mouth breathing in the earliest years of life? Well, this is when our facial structures are growing the most. And our jaws are 60% developed by the age of 6 years. So having the mouth closed and the tongue up, that's actually going to stimulate good jaw development, because it's those light, persistent forces of the muscles that are actually going to have the most impact on the way we grow. And generally speaking, if we have our mouth closed, we're going to get a wide and forward direction growth of our jaws. But once our mouth hangs open, we're going to get a longer and downward facial growth. And this leads to a more sort of retreated airway, because as our face grows forward and wide, that opens up our nasal passages and our throat support. But when everything is going down and back, our nose and our airways are fitting into a tighter space. And so that's why it's particularly important that we pay attention to mouth breathing in the earliest years of life, because we want to have good nasal breathing to drive good jaw and airway development.
Wow. Yeah, it's so important, isn't it?
Mm-hmm.
So at what age should we be starting to work with somebody or start implementing strategies to help our kids if we're noticing this grinding or mouth breathing or all of the other issues that you described? Like you're saying, by age 6, quite a bit of our jaws are developed. Is it before age 6 that we should be working, or is after age 6 too late?
Yeah, definitely. If we want to achieve optimal airway development and have our optimal breathing, we need to focus on the earliest years of life and ensuring the jaw structures are forming correctly. Because the jaw structures, for instance, the upper jaw, it's really the floor of the nose. So that's got to grow well for our nasal passages to grow well. And both the upper and lower jaws are the housing for our tongue. So if we want good room for the tongue, those jaws have to grow well. And as those jaws grow wide and forward, it actually improves the support for our throat, which is that collapsible throat that's prone to collapsing during sleep. And so we need to pay really good attention to the jaw growth. But what we've got to understand is that the muscles provide the functional stimulus for the jaws to grow well. So the tongue has a very, very large role in the upper jaw development. Now, when that tongue is really well toned and lightly suctioned to the roof of the mouth during sucking, swallowing, and breathing, it's actually going to drive forward and wide development of the upper jaw. And so with that lower jaw, it's mainly chewing forces that can help develop or stimulate that lower jaw development. And so in those earliest years of life, what we can pay attention to is really good orofacial muscle function. And so, for instance, from birth, we want to have good tongue function during sucking. And so optimal breastfeeding, or to get optimal transfer of milk from the breast, a baby needs to be able to lift their tongue and suction it to the roof of the mouth. And then when it drops, it creates a vacuum and milk is transferred most effectively. And so we need to ensure good latching and look out for things like tongue ties, which restrict normal elevation of the tongue. Yeah, we want to avoid or minimize things like pacifier use, because that actually lowers the tongue posture. And then what that does is increases sucking pressures, which also collapse that very moldable jaw within those earliest years of life. And what else? We want to promote nasal breathing. So when things go off track, the more and more we can get nasal breathing and restore that closed mouth nasal breathing posture with that tongue up, the better that is, because it's the breathing that we do 24/7 and the light persistent forces of the muscles associated with that has the biggest impact on the way our jaws are going to grow. And, you know, things like chewing, we want children to be able to chew well and use their muscles well, all these things that the muscles do. If we can optimize them early as possible, it will allow a more favorable trajectory of growth. And so if we have things like breastfeeding problems, or problems with chewing and swallowing, or speech concerns with speech sounds and tongue thrusts, and difficulties with the unclear speech articulation, for instance, with lisp, we want to try and get those muscles working better to actually drive proper growth. And those muscles involved with chewing, sucking, swallowing, and breathing, they're all the same muscles of the throat. And so when one doesn't work well, it can tend to impact children in various ways. So yes, how early can we intervene? We want to try to intervene with the muscles as early on. And if we need to restore nasal breathing, looking at what can we do, what are the barriers to that, and trying to address each of those individually.
Yeah, wow. So you'd mentioned tongue ties there. Can you tell us a little bit about tongue ties and like why they're problematic? You talked about that a little bit there, but I wonder if you could expand. And do they always need to be fixed?
Yeah, a tongue tie, we all have a lingual frenulum, which is a connective tissue that joins the flora of the mouth to the undersurface of the tongue. But sometimes these are particularly tight and restrictive, and they don't allow the tongue to move properly. And a lot of the time, people think if the tongue can poke forward, there's no tongue tie. But really what we need to assess is how well can the tongue elevate? Because we need good tongue elevation for good sucking, swallowing, and breathing. And when that tongue can elevate, it's really important for good palate development. And it's really good tone for the tongue, because one of the most important functions of the tongue is as an upper airway dilator muscle. So when it works well during sleep, when everything is floppy, it's the tongue that is really well postured in the roof of the mouth and well toned that's going to help to keep the throat open. And so it is really important that we check for these restrictions, because the tongue has so many important roles in terms of speech articulation and palate development and all those functions. We're really looking for tongue elevation. Yeah.
And when you
Yeah.
say tongue elevation, that's like how it can elevate in the
Lift.
mouth.
Yeah. For instance, we need that really good tongue suction for extracting milk. And sometimes, we need that for good swallowing as well. So sometimes infants, for instance, if they have a tongue tie, they may click and swallow more air because they're not really able to lift their tongue. And this can present as reflux-like symptoms, where babies are more gassy, or they may be more prone to spit ups and vomits, or needing to be held upright, back arching. And that can get misdiagnosed as reflux, and babies are medicated for medications that don't necessarily work, when the actual underlying problem is excessive intake of air, because they're not able to swallow with their tongue lifting correctly. And we need to rule out tongue ties as being a contributor to the poor latch and intake of air.
And what about after like kids are a bit older, say they're, I don't know, 3 or 4 or even like 8, and we realize that they have a tongue tie? Is it worth fixing at that point, or is that a case-by-case basis? Like what do we do if we don't have this information when our kids are babies?
Yeah, it's a very common thing in my practice. A large part of it is dealing with missed tongue ties. So the thing is, it's quite possible. Like, a lot of people think, oh, you don't need to release it if there's no pain, your nipple pain when you're breastfeeding, or your baby is getting adequate weight gain. But it's a simple fact that we need good tongue suction and elevation to extract milk efficiently. It is possible to still breastfeed, but then we adopt compensations. Yeah. And so, for instance, we would actually have a more shallow latch and overuse our lips and cheeks to create the vacuum to extract the milk. And so it may get missed during infancy, and then it can present in other problems later down the track. But even then, a lot of children are just getting by. You can speak, and I've seen a lot of kids with tongue tie that have prolonged speech therapy, and they're not really getting anywhere. And when I kind of watch them speak, a lot of them, they overuse the muscles of their lips and their mouth to make the sounds rather than their tongue. And so all these compensations, the problem with these compensations is that we don't allow the tongue to develop the proper strength and tone that it needs to develop the palate and to work well during sleep, to keep the airway open so that it doesn't become flaccid and block the throat. And so the question is, when do we intervene? Because doing a tongue tie release, it doesn't actually fix all those problems. What we really want to see is, we want to get the tongue working well, particularly in its elevation and suction. And so it's all about timing as well. And so, yes, the best opportunity is during infancy and promoting better breastfeeding, because that's a really good workout for the tongue. And I personally find it really difficult to do maybe the 1 to 4-year-old mark, because when we release the tongue ties, a lot of those children will have compensations. They've never used their tongue and they don't know how to use their tongue. And so we release it, and we're not really going to get the full movement out of it. Yet they're so difficult to do good therapy with. And there's a risk of reattachment where things join because things don't move differently. Very much like taking a cast off an arm. If we take a cast off the arm that's been on there the whole life, it doesn't mean that it's automatically going to start moving. And there will be a risk that it will rejoin or reattach. So it's a really tricky age sometimes. We don't really want to intervene because of that degree of risk of reattachment and things not being able to work as well as they could. So during that age group, I would typically, if it's very restrictive all the way to the tip of the tongue, yes, I would consider a release, but we need to consider working with a feeding therapist or a speech therapist that's going to get that tongue moving well and moving better. And if it's less obvious, I would refer children for therapy in the first instance. And then it would be a matter of getting the tongue to work better and adopting better patterns. And if that person says, I've done the best that I can with therapy, we've got a good result, and this tongue tie is now becoming a barrier to further improvements, that could be a reason to release the tongue tie. And then when children are older, like maybe 4 and above, yes, we can still do tongue tie release. And what we want to do in those situations is we really want to do good therapy, and we want to train the tongue how to work and how to move. And then when we do the release, they actually are able to know how to move the tongue and move it immediately post-release, so that it will minimize the degree of reattachment and preserve as much mobility as possible.
And when you talk about that therapy, is that, again, speech therapy, or is that more like therapy that they would be doing with you when they're older? Is like myofunctional therapy? What would you recommend is the therapy they do side by side with the tongue tie?
Yeah, so personally, I don't really do myofunctional therapy, or our team doesn't do it with children, say 4 and under. Those children are better off doing feeding therapy, where they're using food and placing it in different areas, and tools, little toys to actually get the mouth moving better. And then myofunctional therapy, maybe from 4 and above. So myofunctional therapy is typically with, it could be someone like a dental therapist or hygienist, like a dental professional, or a speech and feeding therapist. And it's normally someone with a health professional background that is working in the area of myofunctional therapy. So they're the people to look for to do the therapy.
And if we're realizing that our kids, say, are mouth breathing or grinding or having any of the other issues that you mentioned previously, would you recommend that we get that type of therapy for those issues as well, even if maybe there isn't a tongue tie or we don't know there is one?
Yeah, so anytime there is, we have mouth breathing or teeth grinding. So for instance, if we know teeth grinding is a strong red flag that there is breathing difficulties, it's basically a stress response. Whenever there's a difficulties with airflow and there is an airway obstruction going to airway narrowing occurring, rather than having a complete obstruction and oxygen deprivation, sleep grinding tends to be a protective mechanism. It's an increased fight or flight response to grind, open up the airway, and protect against sleep apnea. But what it does, it creates chronic stress, and it actually disturbs sleep. So it doesn't allow children to get into deep sleep. So their symptoms are very similar to children that have had complete obstructions in terms of reduced attention, concentration, emotional regulation concerns. And so, yes, when we have teeth grinding, we've got to work out, is there an underlying breathing disturbance? And what are the risk factors in that child? So this applies to whether it's teeth grinding, snoring, or mouth breathing. We've got to work out, what is the airway problem? Is it a problem inside the nose and throat? So do we have enlarged adenoids, enlarged tonsils, or is there congestion or a lot of swelling from allergies? And that can be addressed. Then we've also got to look at the outer borders of the airway. And this is really formed by the jaws. So are the jaws sufficiently positioned forward and wide? Then we've got to have a look at the muscles. So is the tongue working well? Is it sitting correctly? Are the lips closed, or does the child just have flaccid lips because they've never had the habit of closing their lips? And they're probably the main common steps that we've got to address. And every child may have a combination of both. So to get complete resolution, we really need to be tackling it from all angles, and as healthcare professionals, working at it from an integrative approach.
Yeah, it sounds like you would need a number of professionals there tackling each aspect.
Mm-hmm.
So if we notice that it is jaw related, say it's like the jaw structure, what can we do for our kids if their jaws are narrow and far back? I'm probably not saying that in the right way, but like not forward, like you're saying, and wide. What can we do? Can we help to expand that? What are the options?
Yeah, realistically, with orthodontic treatment or orthodontic appliances, we need to have a full set of teeth to anchor it. Yeah, so in my hands or my comfort level, I'm probably not going to treat children much younger than 4. So that 0 to 4 age group, we really want to focus on getting the muscles working better through therapy and trying to address poor muscle habits. But from the age of 4 and above, yes, we can start looking at orthodontic treatment, especially not every person is going to want to offer treatment this early. But for me personally, that's what I do. I do think that the more on track we can get the jaw development, the more impactful it is for children, and to be able to really redirect growth when children are growing the most rapidly and when they need their best quality sleep. And so typically I'm going to focus on the palate or the upper jaw, because that is the template for lower jaw development. We've got to get that upper jaw right before we can to really guide that lower jaw into a better position. And so, yes, palate expansion is what I look at for the older children. So it typically involves some sort of appliance, whether it's fixed or removable, inside a child's top jaw. There's usually a screw mechanism in the middle of the appliance. And when a parent can turn a key, what this does, it separates the 2 halves of the appliance and sort of separates the 2 halves of the palate. And it stimulates new bone in the region of the mid-palate suture or in the mid-palate, which also corresponds to the nasal floor. So as we widen the palate through that bony expansion, we're going to get improvements in nasal airflow. And when we widen the palate, we're going to get more room for the tongue. And as we get more room for the tongue, we can actually restore better tongue posture and get the tongue working better as well.
Yeah, that sounds amazing. So what age can we do that up to? Because eventually our jaw becomes like we can't keep expanding it, right? There's an age
Yeah.
where it solidifies.
Exactly. We have this mid-palate suture, and as we get older, it becomes more and more fused. So around age 9, it's starting to fuse. And then when we try to do this expansion, because there's that resistance to the separation of the 2 halves of the palate, the forces that get applied, they tend to be transmitted across the teeth, and they move the teeth rather than getting that true bony expansion that we need for good nasal improvements or nasal airflow improvements. But nowadays it's possible to expand at any age, because as children get older and older and as we work into adults, we can actually use expanders that utilize mini implants or TADs, temporary anchorage devices. So they're tiny little screws that go on either side of the mid-palate suture, and then you can really screw in an expansion device or the screw mechanism. So when we turn that screw, that separating force is going to be more aligned to that mid-palate suture. We can transmit that force more directly across the mid-palate suture, which means we can move those bones more easily. And sometimes it involves a bit of surgery, but because of that use of the mini implants, it is possible to treat older and older children. And there's a lot more people becoming trained in this area, particularly in places like America, where there is a lot more interest and it's more progressive to be able to find a provider that can offer that, so that expansion is available for all ages.
Yeah, wow, that's incredible. It's nice to hear that it's never
Mm-hmm.
too late, I guess, right?
Yeah.
So if we're looking for a provider and we don't live in Perth and so we can't come and see you, what would we be looking for? Like, is it specifically like on somebody's website that they say that they're an airway health dentist, or what would we be looking for to know that we're going to a dentist that does focus on this area for kids or for adults?
Yeah, it's truly difficult sometimes, because I'm often sharing a lot of my cases and people contact me from all over. They really are struggling to find a provider. And one of the problems is there's not a lot of training that we get through dental school about this and the connection with airway. So it is really difficult at times. And it's not uncommon, like I have a lot of people fly in and out for the treatment because it can be difficult to find a local provider. So I'm recommending that people start with directories that are like the AAPMD, American Academy of Physiological Medicine and Dentistry, or Airway Circle, the Breathe Institute. And these type of directories, they list all different providers, integrative providers. There may be dentists or ENT surgeons or lactation consultants. And I would say, even if you couldn't find a dentist or orthodontist, to be able to connect with someone or a myofunctional therapist, they may have leads or be able to direct you to other people in their network that treat this. Alternatively, what I've seen that's been growing a lot is there's a Facebook group called Children's Paralytic Spinal Support. I hope I got that name right, where parents can pose that question, because there's more and more parents that are becoming interested in this and they're asking their questions to each other. So I think that could be another avenue. In terms of when you're Googling, yeah, definitely you can look for dentists that mention airway or early interceptor treatment. And when you're calling into their front office, you want to be asking questions like, do you offer ENT referral if my child is snoring? Or do you refer out to anyone if my child has a tongue tie to help with the release? Or do you work with myofunctional therapists? And these are all really good clues that they may be more airway focused.
Okay, that gives us a lot of direction. But yeah, it sounds like it's a growing field, but it's still not the common conventional way just yet, but hopefully soon, right?
Mm-hmm.
So are there any resources that you'd recommend for listeners if they want to learn more about airway health and everything that we've been talking about? I know that you have this incredible book, Breathe, Sleep, Thrive, which I highly recommend. Everybody, every parent, every person needs a copy of that book. But are there any other resources that you recommend parents read or listen to or watch to just learn more about this and get really familiar with airway health and this new way of dentistry?
Yeah, the one resource that really comes to mind that I think this organization is putting a lot of effort to collating more and more resources is a group called Children's Airway Foundation, Children's Airway First Foundation. It's called CAF, CAFF. Now they have a website. It has books that parents can read, articles, all different blogs, and they have a podcast as well. So there's all different topics, and it's specifically designed for parents. And their mission is really to promote more airway health awareness, so we don't undertreat children and we can actually improve the quality of their lives. So that would be the one resource that comes top to mind. But yeah, definitely the book. There's a void of information, which is why parents have connected so well with it, to be able to find answers. So I do think that, and I'm pretty active on social media. So even my Dr. Shereen Lim page on Facebook, that's where I post the most. I'm most active on there. And I really try my best. There's only so many people that I can see, but I try my best to promote more information, share different things that other parents can learn from and get more direction for their child.
And how can people work with you? Is it only in person at this point?
Yeah, I can only see people that I'm going to be able to treat. So yeah, generally it's from all of Western Australia.
Yeah.
And
Okay.
yeah,
And what
they
is
can
your
contact
website?
a consult, drshereenlim.com.au.
Great. And is there anything else that you'd like to add that you're hoping that I was going to ask about and I didn't, or just anything else that comes to mind before we finish up?
I think really helping parents to understand that achieving nasal breathing is a key pillar of healthy breathing and healthy sleep. And it's not just about snoring. So sometimes parents might be alert to snoring and they may get treatment like an ENT surgery, removal of adenoids and grommets, removal of adenoids and tonsils, sorry. And that can help reduce a child's snoring. But what we often find is that children have persistent mouth breathing, or maybe there's an improvement. And then a couple of years later, all these symptoms return and their child is still having behavioral difficulties. Uh, but at the end of the day, what we really need to do is restore nasal breathing, get children breathing through their nose again, with their lips sealed. And so we also need to recognize that the palate or the upper jaw has a very important structural contribution to the nasal passages. And no matter what surgeries we do to clear the nose, we actually need to make sure the palate development is on track. And we also need to make sure that when we've improved the airway through interventions like removal of adenoids and tonsils, or remodeling the airway through improving the top jaw, we need to retrain children to reuse their nose and to close their lips. So it needs an integrative approach. And it's not really just about reducing snoring. We want to promote health through achieving nasal breathing.
Yeah, it's so important, isn't it? And like you mentioned earlier, it's not about just snoring, but it's the behavioral issues as well that can come out of that we may diagnose as like ADHD or a kid just having real challenges, but ultimately it comes down to their airways. So it's something that I think all parents should check in with and assess whether their kids need additional support in this area or not. So thank you so much for coming on here and talking to us about airway health and giving us so much information and so many great starting places to go to seek more information. I really appreciate it.
No, Hilary, I really appreciate your interest in the area of airway health and bringing more light to it. I think that if we can all get on the same page and recognize these red flags, there'll be a lot of children that'll be living better, but it's also better for parents and whole families as well.
Yeah, it makes parenting and life just that much easier if we're all breathing well and sleeping well and everything else that leads on from there. So thank you.
Thank you.